This is the NP Advocate podcast, where frontline clinicians share the real human stories behind the barriers in our healthcare system. These nurse practitioners are powerful advocates for themselves, their profession, and most importantly, for their patients. I'm Laura Starr, fellow nurse practitioner, and your host. Welcome to the NP Advocate. Rubi Alva de Hickson is a distinguished critical care nurse practitioner of Hispanic Latina descent. She currently practices in the Department of Critical Care Medicine at the University of California, San Francisco. With over 30 years of experience in critical care nursing, she recently earned her Doctor of Nursing practice from UCSF School of Nursing. Rubi was instrumental in the publication of the accurate Spanish translation for the term nurse practitioner, collaborating with the National Association of Hispanic Nurses to publish a white paper calling for the correct translation. This helped lead to the amendment of the landmark California legislation AB 890 to remove the incorrect translation, Enfermera especializada, from the statute. Rubi currently holds positions as the Policy and Advocacy Chair of the National Association of Hispanic Nurses. She is the legislative co-chair of the San Francisco Golden Gate chapter of the California Association of Nurse Practitioners, as well as an active member of the Health Policy and Practice Committee at the state level. She's also chair of the UCSF Advanced Practice Provider Advisory Board. Please join me in welcoming Rubi to the podcast. Hi, Rubi. Thanks for joining me today. How are you?
I'm doing fine, thank you.
Okay, good. Well, thanks for coming. I'm excited to talk about all the great work you've been doing and have done in the past. This is a nursing podcast, though, so we'll start at the beginning. Tell me how you got in. Tell me why you got involved in nursing.
Well, I have been a nurse practitioner since 2011. I've actually been a nurse for 30 years. Half the time I was a critical care nurse, bedside nurse, and for the other half of my career, I've been a nurse practitioner in the ICU.
What made you initially choose nursing as a career?
Actually, it was by accident. It was nothing that I ever intended to do. I grew up in a small little town called El Centro, California. That's down south, desert little city. And I wanted to be a physician. So I was in pre-med and met my husband when I was in college. And I said, well, it's going to take me a long time to be a physician. I'm going to try this nursing. Lo and behold, I did not realize that was the best decision of my life. I never knew that there is so much to nursing. I have loved it ever since. Nobody in my family has ever been a nurse. So I'm first generation college student. I'm a first generation nursing, and now I'm a nurse practitioner, and I love what I do.
Great. I feel there's so many different ways people get into nursing. I feel like it's really interesting to hear. Were you a critical care nurse the whole time you were a bedside nurse? Was it like general critical care, MICU? What did you do?
So more of a surgical trauma ICU nurse. First year, I was actually an orthopedic floor nurse. I got my 1 year experience. Then I tried home health for 1 year. That was a lot of driving, and I loved it. I put in PICS in the middle of the night. I went and assessed patients. I was a case manager. I really didn't like the traveling. So I went back to the hospital and I got into ICU, and I've been there ever since. And I've been in multiple hospitals. The last two hospitals were level 1 trauma centers. Nice. And now I work in an academic center.
Okay, cool. And what made you decide to take the jump into being a nurse practitioner?
Oh, goodness. So I was here in California when the legislative bill came about where you had the nurse ratio laws here in California. And I advocated for that. And then my husband took me to Connecticut for his job. So I ended up working at a level 1 trauma center. And lo and behold, I did not understand that outside California, there are no patient ratio laws.
Yeah. Yeah.
Yeah, I was in a level 1 trauma center where you did a lot of transplants, you had trauma, and it was a fast-paced ICU. And one night I ended up having 3 patients, triple pressors, being the charge nurse of the ICU plus the step down. And I thought, OMG, this is not working out. So the next day I went straight to the University of Connecticut and signed up to become a nurse go to school for a nurse practitioner.
Yeah. That sounds a little familiar. I was a bedside nurse on the East Coast, and it's a different ball game out there. Well, that's great. So what have you mentioned that you've been in critical care the whole time you've been a nurse practitioner. Also mostly surgical trauma, or like what kind of critical care are you doing?
So right now, as a nurse practitioner, I go in and out 6 different ICUs. I do 2 CT surgery ICUs, 2 neurocritical care ICUs, and 2 surgical ICUs. So I go in and out of different ICUs, not all at once, just one ICU at a time. It's a lot of different ICUs, but I'm one of the few NPs that can do all different ICUs.
Yeah. That's what a great skill set. Let's talk about, those of us in California are familiar with AB 890. And I think maybe not everyone who is familiar with AB 890 noticed the Enfermera Especialista phrasing in there. Can you tell me how you felt when you first saw or heard about that part of AB 890?
So, as I said, I started practicing as a nurse practitioner in Massachusetts. I worked for the University of Massachusetts in Worcester, Mass. And I came back to California, in Connecticut and Massachusetts. Nurse practitioners have their full practice authority. So when law was coming into California, of course, I was so supportive. I said, yes, definitely. Nurse practitioners can have their full practice authority. I supported the bill. I was part of CANP. Of course, I let everybody know. And I advocated for that bill. And then it was signed in 2020, September 2020, and it didn't go into effect until January 1st, 2023, I believe. And then we had a town hall at UCSF where I work, and we had a town hall that let us know about the notice to consumer part of AB 890. Now, sometimes we advocate for legislation, but we don't read the fine print. This was one that I did not see the fine print. And written within the notice to consumers, it mandates by law that we, as nurse practitioners, Hispanic nurse practitioners, introduce ourselves as Enfermera Especializada. When you translate that, it says you are a specialized nurse, not the nurse provider role, but a specialized nurse. So when I heard that, I thought, wait a minute, this is not the proper translation. So I got onto the call and just, I explained on that AP town hall that it was the wrong translation. And they told me, well, that's the BRN. And I thought, okay. I went to the next BRN meeting. I got on the call again. I told the BRN that this was the wrong translation. And I was very surprised that everybody on that call at the Board of Registered Nursing knew that was the wrong translation. And they told me, this is a legislative issue. This can't just change it. As I thought, well, I just let them know I'm a Hispanic nurse. This is it.
Sure, this is common sense. It's not the right way. This is right. It's just an oversight, surely.
Yes, it's change. And no. And so I actually had to go to Jim Woods, the original writer of AB 890. Now, he was not willing to change the legislation. He did not want to open AB 890. Was instrumental in telling me who actually did that translation. So then I had to go to that group. It's the California Legislative Latino Caucus here. So I went and asked them, but lo and behold, I didn't learn. I learned that there was no nurse representing the nurses in this translation. And I had to do a lot of research. At that point, I was in my DNP at the University of California, San Francisco, and I was doing a different project, something that I had been working on for 7 years. And I was doing, I was doing something else, and lo and behold, after getting all this information, they were telling me, well, you need to get the National Association of Hispanic Nurses to agree that this is the right translation. So I flew to Oregon, and I went to their national conference. And there I Zoomed in with one of my professors, and she said, "What are you doing in Oregon?" And I said, "Well, I'm here advocating for the Nurse Practitioner's translation." So after everything that I was telling her about this translation, she's like, "You have to do a DMP project on this." And I'm like, "Wait a minute, I've been working 7 years on this project." And she's like, "Ruby, just publish it already. But this is going to change nursing." And I thought, well, it took me a while, but then I said, okay, well, I'll take it on. And so when I went to the National Association of Hispanic Nurses, now they are the national organization that speaks for all Hispanic nurses in the United States. Right now, there is a House Resolution Bill 757 that is requesting September 22nd to be National Hispanic Nurse Day. It hasn't gone through yet, but we're advocating for it. And we have over 3,000 members strong. We have 47 chapters throughout the United States. And if the voice of a Hispanic nurse agrees that this is the correct translation, they would probably change the laws here in California. Now, what's really interesting is that of all legislation in the entire United States, this is the only time in California that it mandates you how you translate your title. Nowhere else has this ever happened. So this is important. And as you know, in California, things start and it goes throughout the United States. We're just a little late to the party about having FPA, the Full Practice Authority. We're 27, but usually things start here in California and then it goes throughout. So I knew if I didn't translate that, the nurse practitioner through for non, it's other people are going to start using the Enfermera Especializada translation, and that's incorrect translation.
Slight backtrack out of curiosity. What was your original project going to be on? Oh,
it was a comfort care huddle checklist. When you're in the ICU, how to withdraw a patient from, the ventilator or another device that is keeping somebody alive was very important. I came from the East Coast where the decision to take somebody off a life support, it was ordered, you went, you did it, but there was so much chaos and it was together, and there was so much evidence that a lot of the nurses, the bedside nurses that were withdrawing care, took a lot of that within themselves, a lot feelings that, they were alone. So this comfort care huddle checklist that started at UCSF in 2015 has been great as an ICU nurse. Because what happens is whenever you're going to withdraw a patient, you have a checklist like, is the patient and family ready for this? Has there been education? What are the medications you're going to use? Is everybody on board? What is the procedure? And how are we going to do this? And we come together outside the patient's room with the chaplain, with the bedside nurse, with the respiratory therapist, with everybody involved. MCS, the mechanical circulation services, and how we're going to withdraw this patient. And we want a good death. So this is, when I saw this checklist, I thought, oh, this is great. Now in UCSF, I work in an academic center where everybody just kind of, somebody brings in this idea, they work on it, everybody's collaborative, it's an education place. But I wanted to take this tool that we use to another hospital, to other major hospitals. So that was going to be my project.
Gotcha.
But it's something I was for 7 years. I had at 2 major organizations, and it went well. But I thought, okay, I could do this for my DNP and then publish it, and then everybody would know about this withdrawal huddle checklist.
Yeah. Well, I mean, that sounds great. Hopefully it's still making its way out there. Back to your work with the National Association of Hispanic Nurses, or NAHN. Had you already been involved with them before you heard about this?
Yes, I was already a non-member. One of my professors, when I started my DNP, very instrumental. She said, "What do you want to do with the leadership degree?" And I said, "Of course, I want to change practice. I want to be a leader." And she's like, "Well, are you part of the National Association of Hispanic Nurses?" Now, I had never heard of this. And it's crazy because at that time, it was much smaller. Now, we are now much more vocal, and advocacy in the last 2 years, we've almost doubled our membership. So the more exposure, the more reasons that we are growing. So I had started right there in 2022, and I wish I would have known about this organization many years before. But I'm so happy that I am part of this organization. I am part of the San Francisco chapter. I'm now the president, and I'm also the national chair of policy and advocacy. So I have a lot of opportunities to change our practice and just to make people more aware of legislative issues.
Yeah. So when you set about to sort of finalize the Spanish language translation of Nurse Practitioner, what were, like, you approached non-leadership. What was the process from there? Like, did you guys already have a phrase? Because correct me if I'm wrong, the nurse practitioner role isn't necessarily prominent in Spanish-speaking countries. So I don't know, like, you guys had to come up with this translation. Is that accurate?
So there was already a translation in place. If you go onto Google, you can see the translation of CVS Pharmacy, Walgreens, Kaiser Permanente. You can go into many organizations, how they translate the nurse practitioner. So part of my project and part of my white paper that I sent to the Association of Hispanic Nurses was based on my research. So they translated the nurse practitioner as Enfermera Practicante, kind of like a direct translation. You say nurse practitioner, Enfermera Practicante. But, and you're absolutely right. In Mexico, Central America, and South America, there is no nurse practitioner role. There's only the nurse, the registered nurse, and the CNS, the certified nurse specialist. And those are the only 2 roles in Latin America. So I had to do a lot of research, seeing how they always translated the nurse practitioners, because a lot of our nurses and our Hispanic people are coming from Latin America. So I went into a lot of literature, and whenever they talked about the nurse practitioner role, they always say la enfermera practicante de los Estados Unidos, means the nurse practitioner of the United States, because they really didn't know the role. So when I was doing all the research, there was a translation called la enfermera de práctica avanzada. When you say enfermera de práctica avanzada, that means the nurse of advanced practice. So that's kind of like your umbrella term. As you know, it's almost like the APRN, the advanced practice registered nurse, which is the umbrella term for the nurse practitioner, the CNS, the CRNA. So it is the certified nurse midwife.
Mhm.
So you know that that's an umbrella term. You say advanced practice nurse, but specific to the nurse practitioner, it's the Enfermera Practicante Avanzada. So in Mexico, they have the Enfermera Practicante, but guess what? That is the nurse LVN level. It's a practicing nurse. So when you
Mm.
say Enfermera Practicante, a lot of your Hispanic people will say, why am I going to a practicing nurse? That's not a provider. So
Mhm.
that's that's why a lot of Hispanics will go to urgent care, will go to the hospital, and they just don't understand the role of the nurse practitioner, that they can diagnose, they can treat, they can prescribe their medications and treatments and follow them through their course. So in my research, I was finding that when AB 890 came about, a lot of the Hispanic community was saying those nurse practitioners were lying to us. And I'm like, whoa, I was taken back. I'm like,
Yeah.
what do you mean? Well, it's because when they would say doctora, because they saw them as a provider, the
Mhm.
nurse practitioner didn't correct them because they didn't know the translation and they didn't know
Mhm.
that they were actually being seen as a physician.
Mhm.
That's why it's really important that the nurse practitioner, even though you don't speak Spanish, you know that translation, that you
Mhm.
are an enfermera practicante avanzada. And that avanzada part changes the practicing to practitioner role. So when you say
Mhm.
enfermera practicante avanzada, that avanzada changes it to the nurse practitioner. So
Mhm.
a lot of it is more of the education of our community, that they need to know that nurse practitioners are available to treat them. In all this research that I've been doing, it's
Mhm.
amazing that California advanced practice providers are 30% of all providers in the United States,
Mhm.
40% nationwide. If our Hispanic community, now we make up 20%, Hispanic people make up
Mhm.
20% of the United States population. But here in California, we're 40%. And there's been a lot of research that will show such a percentage of people going to urgent care and the hospital, and they're only Spanish speaking, and they need to know that they don't have to go to the hospitals and urgent care. They could actually make an appointment with a nurse practitioner. Uh,
Mhm.
so that's how that came about. And it's really important that the Hispanic population that is coming from Mexico, Central America, South America really know who we are. It's
Mhm.
amazing. There are 385,000 nurse practitioners in the United States. Here in California, we're 44,000 strong. I love my profession. I just want more people to know that we are available to help and to really do excellent care to take
Yeah.
care of our population.
You've done a lot of fantastic work on this. Is there like a patient story or a story from your family or like something that like why is this important to you? What like can you think of a time that just like drives this home for you?
I think when I heard somebody say the nurse practitioner lied to me, I think
Mm.
that has really struck a chord with me because, as you know, as nurses, we're seeing, nationally that they can trust us. And
Mhm.
for a patient's trust is very important to me, that they know that
Mhm.
I'm not lying to them about who I am and my role and what can I
Mhm.
do. Sometimes when I first started as a nurse practitioner, and they used the word enfermera practicante because I didn't know that really one time somebody called me a doctora, and
Mhm.
I told them, no, I'm sorry, I don't have my doctorate. I'm not a
Mhm.
physician, I'm a nurse practitioner. Then I Googled the translation, and of course, it gave me enfermera practicante. And that's what I was using the entire time. So
Mhm.
it wasn't until my research and my DNP project that I really realized you actually need that avanzada.
Yeah.
For me, patient trust is so important, especially in my place of work. I work in ICU. I make critical decisions. I
Mhm.
do a lot of teaching, and I do a lot of family meetings. And I want them to trust that what I'm saying is truthful. Uh,
Mhm.
if I was to say I'm Enfermera Practicante, and that person, that Hispanic person that speaks Spanish, looks at me like, could you be talking to me about these critical issues? And so for me, it's very important that my community understands the role of the nurse practitioner.
How have you seen this play out in your job, in your family meetings, when you're Spanish speaking patients? Like, do you I guess, do you often have a relationship with these people before you're having family meetings? Or I know sometimes you're like, I wasn't on yesterday, but the family meetings today. Like, how does this help you form that therapeutic relationship?
Yeah. I'm really a big advocate for provider concordance, meaning somebody that looks like you, that understands your culture, understands your language and where you're coming from is important. I was a little shocked to that only 8% of all nurses are Hispanic in the state of California and probably throughout the United States. When sometimes that really hits home, especially when I'm on service and I know that they've had a catastrophic bleed. Just take an example. I'm working in a neurocritical ICU. Somebody's had a catastrophic bleed and the family is holding on to all hope that the patient will survive this catastrophic bleed. And some of my colleagues will say, we try to explain to them, they're just not getting it. And the patient has coded already 2-3 times. And when I enter, I'm like, wait, you can't keep doing this. Somebody needs to speak to this family. So I will hold a family meeting. I will talk to them and I will encourage my colleagues to enter into this discussion, but I will bring in. One thing that I do is I do bring the translator. We have like this little translating unit that comes in. But not everything is translated so that the patient's family could really understand what's going on. So I bring up the CT scans. I bring up what's going on with the patient and what is happening and why this person continues to code. Usually after I talk to them, the family will withdraw care. And as they've been shown these images, they've seen somebody that speaks their language and understands what they're going through, will be able to be having that honest discussion. And usually the families will withdraw and somebody will say, hey, we've been trying so long. Well, I wasn't on service that long, But when you really understand and you're able to communicate is very important. I think, and sometimes you'll find patients when you come onto the service, they've been holding on to something, and then you say, you speak Spanish, can I help you? Then all of a sudden you hear everything that has happened, and they'll be able to tell you. And I thought, well, why weren't you were able to say this to the nurse or to the providers coming in, but it's because they trust you and they trust your, you understand them. And I think even if you're not Hispanic and you show empathy and you show that you care and you're able to demonstrate what is going on, you have a different response. And I think that is really good about nurse practitioners in these areas. A lot of times, one of our physician colleagues can go in there, explain something, and then you kind of see that they're not really understanding.
Yeah. We've all seen that look on patients' and families' faces. Yeah.
And it's great because then you just know that you've made a difference in this family and that you've connected with them. And these are difficult decisions and critical.
Yeah. Yeah. Like you said, I think the circling back to the trust piece. I think it's so, we can't change our skin color, but we can connect with people on their level and where they're at. And that's so much, it's harder, but not impossible with a language barrier. So I think you you putting the work in to get a translation that fit and was established and uniform and had that cultural background, I think is really important for just that baseline level of meeting people where they're at, having a basic understanding of who's who in the room. I'm not fluent in Spanish, but I can introduce myself. And so for a while there, I'd read the regulations and I was like, "Hi, I'm an Enfermera especializada," and they're like, "Huh, who's this white chick in here, and what are you doing?" Um, and so like it's great to sort of have the legal freedom to introduce myself properly, and then establish that hopefully rapport with the patients.
I think people just appreciate, even if you are not Hispanic, just even trying to say hola, just
Mhm.
just that human connection. And that's what nursing really teaches us, is that the person on that bedside or the family, they're human. And
Mhm.
just to have that connection, I've seen people where I just stay back. Now, a lot of people will see me and sometimes they don't realize that I'm actually Hispanic, but I'll see a
Mhm.
provider try to talk to the family, and just the family's response to somebody even trying to speak their language.
Mhm.
It's a connection.
Mhm.
I've been trying to learn other languages. We are a multi linguistic place in San
Mhm.
Francisco. So as one of, I'm also the chair of the UCSF advisory board. And one of our projects is to put out a video on the top
Mhm.
5 languages in San Francisco and have the
Mhm.
translations of all advanced practice providers, the nurse practitioners, the PAs, the certified nurse midwives,
Mhm.
at UCSF for next year for APP week. So we're hoping to do that because it's not just Hispanics, but we're talking about other languages that are
Mhm.
so important that they understand who we are as providers.
Mhm. Yeah, absolutely. So I guess a follow-up question to that, Ruby, I love, you are a frontline clinician. Correct me if I'm wrong, your primary job is to take care of patients. But you're involved in all of these initiatives and organizations. Where do you find the time and how do you prioritize?
Well, I am so grateful. I am, to translate the nurse practitioner, I had to get a lot of stakeholders,
Mm,
different stakeholders, from my initial non-group to the CAMP, California Association for Nurse Practitioners, the organization that actually speaks for nurse practitioners. And then I had to get involved with the, the, um, the National Board of Non. But
mhm,
everything I've been doing is a lot of legislative review, legislation. That's where I'm really, a lot of our legislative bills go from one organization to the other. And
mhm,
so it's not difficult for me. It's not like I'm having another, whenever I'm talking to CAMP, I'm always talking about the legislation. I'm the
mhm,
co-legislator at San Francisco CMP. So I share
mhm,
this chair with 2 other people. And
mhm,
so I'm more of the communicator between the state board, the Health Policy and Practice Committee there, and then I bring it back to
mhm,
the San Francisco chapter. And so I just sent out an email on all of the legislation that was signed by Governor Newsom.
mhm,
And some of those are I was just impressed in bills that we were advocating for as nurse practitioners. I would say about 90% were passed and signed.
mhm,
Critical legislation that will change the practice. Now, at the national level, at the
mhm,
national level, I do a lot of policy and advocacy. I've been able to, we meet once a month, and I have a committee that works with me. And we've been able to put out policy information. We were able to start a legislative national tracker for Hispanic nurses. We've been able to do a immigration statement and toolkit and a brief. So
mhm,
I don't work by myself. I have an entire committee. Yes, I'm the one writing, and then I get more information from
mhm,
my committee members, but in a whole, we work together. This is just under my leadership. I think we've done a significant change. I just wrote a letter to our judicial system, something that I would have never done.
Yeah.
As you know, the Supreme Court Justice Kavanaugh has really been able to say, hey, racial profiling is okay. And I was just shocked at that. So at a leading organization, we can write a nice letter and say, this is probably not a good thing for our community, and be able to advocate. SB 81 here in California, I was so excited, where we are now protecting our patients' rights when they come into the hospital. This passed, where ICE cannot come into the hospital without proper notice and proper warrant. And I teach our nurses that, just given those rights that we have, the right patient, the right medication, the right treatment, all of those rights, even protecting our patients' rights should be part of that rights, that we should honor our patients. I think because immigration is such a big area of concern for my community, that's why we're very outspoken. And that is one of our priorities when we go to Washington, D.C. As part of this chair position, I'm the chair of a Hispanic Policy Summit in Washington, D.C. And we've had this for the last 3 years, I think. We're in year number 3. No, 4. I'm sorry, 4.
Cool.
And, we go to the legislators and we advocate for different bills at the national level that we, access to care, of course, immigration policy and environment. A lot of what, we have to advocate is for environmental justice. So a lot of this just kind of cross into from one organization to the other. And really, really appreciate Non giving me this opportunity at the national level to be able to advocate for our needs.
Yeah. Tell me if you've come across this, because these are, some of these are polarizing issues. And what, has someone come to you and said, oh, well, I support this, but I don't know if we should be vocal about it. We're going to anger people, or we're going to alienate people. What are your thoughts on that perspective?
So, I think it's very difficult because we are a very polarizing area in the United States. As you can see, you're either really right wing or you're really left wing, and there's really between. I have one thing in my DNP when I was advocating for this translation at the international level, at the International Council of Nurses. I had spoken to a person from ICN, and I was advocating for the translation. And she said something to me that really shocked me. She said, Ruby, who will support you and who will not support me? And when she said that, I was shocked. I was like, how could you not support me?
Yeah. This is going to be universally accepted. It's so obvious, right? Yeah.
First time I ever thought somebody would oppose me. When we do these statements and when I talk to some people, what I really like about law school is that they teach you not just look at what your position is, but what's the opposing side's position, and be able to counteract that and just kind of strive to be in the middle, very neutral, not taking one side or another, but bringing in that other side. I have had people where they say, you know what, this is very, we have to be seen as neutral. And I said, yes, but the thing is, we need to be able to show why we're advocating for this. I think in a respectful manner, but just because we are a nonprofit doesn't mean we can say, hey, these things that are being done is not right, and we have to advocate for our community. But I have learned, and I'm not as shocked anymore. I do really run a lot on issues. issues that really, and you need to learn how to support that issue. Say, and I always bring back the mission of NON, the mission of CANP, California Association of Nurse Practitioners, UCSF. Oh, I bring back their mission and values. This really supporting that and having a connection of the issue with the mission and values. And that's what really I learned from my DNP time at UCSF to really get our stakeholders' input and agreement. And it really teaches you that everything that comes on the board, when you're in a board meeting, a lot of the discussions is before the board meeting, and to make sure you have those connections and make sure that you have somebody supporting your issue. I've learned a lot from the DNP program. Being a DNP, my DNP is in leadership. So learning the structure of a board, learning how they make decisions and why we make decisions is very important to me. That I've learned.
Yeah. Well, I think we've sort of covered the things that I hope to talk to you about this time. I think, like we were talking about earlier, I'd love to bring you back and explore some of these other issues in more detail in a separate conversation. But do you have anything that you wanted to say that we haven't touched on, or any thoughts that you want to end with?
I think my one thought is, this year at UCSF, we had an APP Grand Rounds. We have one every year. And we brought people from the different advanced practice provider specialty organizations together. And what I've learned is that you have to collaborate together with all your APPs. Like we had somebody that represented CANA, the California Association for Nurse Anesthetists. That's from CAPA, the California Association for Physician Associates. We had somebody from the Certified Nurse Midwife group, and we also had somebody that represented the nurse practitioners. We need to make sure that people know you need to be part of your organization that speaks for you. CNP is important to know that all nurse practitioners, we are 44,000 strong here in California, but our membership is not that great. And CANP really speaks for the nurse practitioners. Just like if I would say, if you're a Hispanic person, go become a member of NON, the National Association of Hispanic Nurses. If you're a registered nurse, you want to be part of the ANA. I'm part of the ANA too. So I'm part of the many organizations, but you want to be putting your efforts into an organization that's going to speak for you and your profession. And that's how you're going to change. I think that is my big takeaway, is that if any listener out there is involved, engaged in these professions, professional organizations that speak for you, because they will hear you, they need your membership, and they really need your viewpoints, because the more you have, the better and stronger you are as an organization.
I 100% agree. You're speaking my language. Well, I think that's a great sort of final thought. Thank you so much for taking the time, and I'm sure we'll be working together in the future.
Well, thank you, Laura. Thank you for having me on, and thank you for letting me be part of this podcast and having a platform to make sure that nurse practitioners know their appropriate translation. California and worldwide. At one point, we are going to get it internationally changed. But thank you for this opportunity.
It's been an absolute pleasure. Well, let me know when you're ready to come back.
Thank you.
Yeah. Here's a little more information on legislation mentioned in today's episode. House Resolution 7057 is a federal bill introduced into the House of Representatives. It designates September 22nd as National Hispanic Nurses Day and recognizes the National Association of Hispanic Nurses as the leading organization representing and advocating for Hispanic nurses. Senate Bill 81 is a piece of California legislation that was signed into law by Governor Newsom on September 20th, 2025. It classifies immigration status and place of birth as medical information, which requires a warrant in order to be disclosed to law enforcement. It also prohibits healthcare institutions from allowing law enforcement access to non-public areas for immigration enforcement purposes. That's all for today. Thanks for listening and hope to see you next time.